failure, and this is one of my cases which I'll discuss. And the question which often got asked is, why have my cycles failed? Again, that's a question mark, and there's no investigation that can tell you why treatment cycles fail completely. And also, are there any tests? And let's look at the general evidence. So this is a lady who is 39-year-old, had 3 IVF cycles, 4 IUIs, from about 38 years of age for a year. Total of 8 blastocysts were replaced, negative pregnancy test, a good AMH, normal thyroid, sperm normal, open tubes, hysteroscopy was done after a third failed transfer, and the endometrial scratch was done. So we started with a new cycle on a mild stimulation with a dual trigger. 9 oocytes were obtained, 7 fertilized, and she had a good blastocyst conversion. We did a genetic screening of embryos, that's PGTA, and we decided that once we get the results, we'll do an endometrial assay, followed by a rebiopsy and a frozen transfer. So when you look at the genetic screening, you had 3 embryos which were normal and 2 which showed genetic abnormalities at chromosome 12 and a complex abnormality. So then we proceeded to doing the endometrial triode test. Now, what is the endometrial triode test? And it is mimicking a frozen transfer, but except for the exact time of doing the embryo transfer, you take a biopsy. So what you're asking is the question is, are we implanting the embryos at the right time, let's say 120, 125 hours, or should we implant it earlier or later? The MR test looks at endometritis, but also looks at endometrial flora, lactobacillus. And ALICE looks at bugs that cause endometritis. So when we got the ERA test, it said it was pre-receptive, which basically means that the duration of progesterone was inadequate and you needed to give more progesterone. And so the embryo transfer was not done after 5 days of progesterone, but after 6 days of progesterone, and that is on the next day. When we looked at the MR test, you look at the lactobacillus, 0. What causes a drop in lactobacillus? Infection. And you looked at streptococcus infection, for which antibiotics were given and probiotics was continued. The rebiopsy came out showing a clear infection. There's a viable 12-week pregnancy. So let's look at the causes of implantation failure, and there are multiple. In male, you look at sperm DNA fragmentation, and aneuploidy. With women, age again is the most important factor. You look at equality and abnormalities in embryos and uterine abnormalities. Why is genetics most important? As women age, just have a look at what happens. Even at young age women under the age of 35, almost 50% of blastocysts are genetically abnormal. By the time you get to the age of 42, 80% of blastocysts may be genetically abnormal. Now, the question gets asked is, why don't we do this test on everyone? Because the evidence is still limited. We are still not entirely certain whether doing general screening will give an improvement in chances of pregnancy, whether tests like the MR, ALICE, and ERA test are very well validated, with research showing that in some cases they literally do not give good evidence of it working. So again, much of that is in the gray area. But again, when couples undergo repeated implantation failures, where do we go? We go towards finding out whether the chances of pregnancy can be improved by trying to push science to a certain level. And these are the investigations that probably tell us so. Let's go back to a diagram which I draw, and I say, what are the causes of implantation failure? One is, it could be the embryo. It could be an abnormal embryo. It could be an embryo which is nuclear abnormality or mitochondrial abnormality. The talk between the embryo and the endometrium could be affected, and that's immunology of implantation. Can we investigate it? Not very well. Let's look at endometrial problems, and then you're looking at whether they're high hormonal levels, such as high estrogen levels, high progesterone levels before egg collection. Freezing embryo can address it. Again, at embryo transfer, is there adequate progesterone? Is there endometrial advancement? Are there adhesions? Are there fibroids? Is there a thin endometrium? And all these, if you look at it analytically, one by one, you may be able to get to a large number of repeated implantation failures. The question is, find the time and go stepwise into each area. Also, remember that at times you may have to move the implantation process from a medicated one to a modified natural one. The reason is that the natural cycle tends to have a much better understanding into how implantation occurs. The implantation window is much wider in nature, and sometimes you'll have to take investigations such as this, which may help you to get to a pregnancy easily. Or rather,